one of the endotype which requires even long-term oral steroid post-surgery. So this is a pure type 1 hypersensitivity reaction. CCAD, central compartment atopic, is a different endotype, which is basically a complication of untreated allergic rhinitis. That requires a sinus surgery followed by allergic testing immunotherapy. Cystic fibrosis is a different endotype which is prevalent in children. And for me, any child, young child with bilateral nasal polyposis should be considered cystic fibrosis until proved otherwise and must get a sweat chloride test to confirm it. So you have to be suspicious about it. So there are variety of endotypes of CRS and every endotype has a different underlying pathophysiological process which need to be corrected, it need to be addressed accordingly to get optimized outcome. All patients cannot be treated on the same line. So as you asked, assessment is the most important part of the overall management, and patient profile, immune profile, everything, allergy profile must be thoroughly assessed.
Thank you. So what is your surgical plan for this case? Is it any different than the last question?
Bilateral full house fest.
Yes.
Massive, I would say, mega enterostomies in this case to deliver more steroid inside as a more profile, more inflammatory, severe inflammatory profile of this patient demands more, vigorous topical steroid douching in the post-op. So
Thank you. And this might be a good time to ask you about the frontal sinus. Given the extensive involvement of the frontal sinus, do you consider primary Lothrop at any stage? Or what is your sort of place of Lothrop in the management of such cases?
Very important question. I tell you, primary Lothrops means patient who is unoperated and having CRS, not operated earlier. I would still do a Lothrops in primary setting. In the first surgery, if the patient has a AERD. AERD patients in first setting head on, we do Lothrops to give maximum opening for the highest topical douching, highest topical steroid douching. Out of all these endotypes I mentioned, AERD is one which is at the extreme of the spectrum having highest inflammatory profile. So these are the patients, if diagnosed on the primary setting, I would go ahead with a Lothrop in the first go to prevent the need of, going for it again. And post-surgery, after a couple of weeks, we'll schedule decent.
Thank you.
So we go ahead with the surgical course, we can continue discussion. Any questions from the audience on anything, please share with us.
No, so you can start with the case.
Okay.
That's going to be an interesting case, looking at the extent of the disease.
Yeah, completely blocked. Polyps throughout both nasal cavities with no nasal airway at all there. So the patient should have a huge relief after this surgery, finally able to breathe again through their nose. Do you use any aspirin desensitization in your AERD patients, Ashok, or?
Yeah, I do some difficult patients. You end up having quite a few of them. If you refer for aspirin desensitization. But the challenge is with the waiting lists and other thing key is what Dr. Sati said about timing. So the timing should be perfectly matched with the surgery. So it requires a good coordination between your respiratory medicine, allergy colleagues who offer the desensitization service.
And do you have good compliance of your patients with it and good results with aspirin desensitization, or?
That's the challenge with it. So you really rely on patient compliance, and they really need to persist even after desensitization, because if they miss the dose even for say 72 hours or so, you have to start the whole process all over again. So it is a challenge.
Yeah, no, it takes a great commitment from the patients to be involved and on board with doing it.
Absolutely, yeah.
I think
Charing Cross.
Yeah, similar to you. And I think we get patients complain of gastrointestinal side effects or worried about GI bleeds and things like that. So there's quite a lot of patients reluctant to take a high dose of aspirin every day. I know Professor London Glenys Scadding used to use the nasal lysine aspirin challenge and use it topically, and they used to get fantastic results of that. But at Charing Cross, we only have the oral aspirin desensitization available to us. So, and it's our immunology team that run that for us.
Okay.
All right, looks like we're beginning to get an endoscopic view. So there's a nice big polyp. Yeah. So we'll go over to Nagpur.
I think while they're setting up, maybe it's a good time to catch up with our supporters. It's a very brief informational video, and by the time they prepare and get started. So,
okay.
So we do that with some videos. The minute they're not ready, we'll go back to them. Can I ask Studio to play some videos? I think they're busy trying to establish a connection with Nagpur while they're setting up the videos.
So I was going to ask, so is your pre-op regime for CRS with polyps similar to Dr. Jane Ashok? Do you use preoperative oral steroids or topical steroids? And do you give antibiotics preoperatively? Because that was something that I don't generally do unless there's an obvious infection. So I'd be interested what your approach is as well.
I mean, a case like this, for example, I would certainly give a week of steroid. This patient would have previously treated with regular saline nasal pushes, then betnesol nasal drops, along with the course of oral prednisolone. And then I would give them 2 weeks of preoperative course of doxycycline or clarithromycin, depending on the medical condition. I prefer the doxycycline.
Hello.
Yeah,
Yes, sir.
we're connected again.
Hello.
Hello?
Hello.
Hello.
Hi there.
Hello.
Can you hear us? Yeah.
Yes. So are you getting endoscopic picture?
Yes, sir.
Yes.
And you can imagine the disease.
Yeah. Huge polyps.
Yeah, we can imagine the suffering patient that we have.
Hmm?
The suffering of the patient we can understand.
Yes. So full nasal blockage, eosinophilia, massive polyposis. So just typical, like last case, the topical preparation, no infiltration. Apply gently adrenaline on the surface. And see the beauty of marrow cell, absolutely atraumatic.
Is it 1 in 1,000, sir?
Pardon?
1 in 1,000 adrenaline?
Huh?
Adrenaline concentration that is
Yeah,
been
1
used.
is to 2, 1 is to 2.
1 is to 2.
See now, after the first application, decongestion. See, I can see the axilla now.
Yes.
See, the nose has opened up. See the polyp. See the axilla
Yes, sir.
Yes, sir.
and polyp medial to the middle turbinate as well. This is a very important findings to notice because polyp medial to the middle turbinate are responsible for olfactory loss as well. They destabilize the turbinate, middle turbinate very often when having disease on either side. And most of the time, such patient requires a sort of partial turbinectomy to handle the destabilized turbinate so that the irrigation can be thoroughly given a way to olfactory recess. Sorry, see the opposite side as well. Massive polyposis. So interesting case.
Hello.
Yes, sir.
Sir, you commented about cystic fibrosis.
Yes.
So can you put more light on that? And because
Okay.
in Indian scenario, we
Yeah, it's
not that common.
Yeah.
But any pediatric patient coming with bilateral full house
Like
disease.
the youngest child I have operated is 2-year-old.
Okay.
2-year-old child with bilateral polyposis. And you know that disease, this is basically because of the failure in mucociliary clearance, because of the viscid secretions. The issue is those polyps are not eosinophilic. In cystic fibrosis, those are purely neutrophilic polyps.
Okay.
Steroids have no role. What all required is a topical antibiotics to control the infection, to prevent lung failure and lung transplantation, need of lung transplantation. Because that contributes to the lower airway infection, lung infection. So those patients require a wide openings, bilateral medial maxillectomies, bilateral turbinectomies, a sort of gravitational drainage into the nasal cavity, and then topical steroid, topical antibiotics to control the infection. You can introduce high dose topical antibiotics without any side effects. And in cystic fibrosis, typically the infection is Pseudomonas. Pseudomonas infection is predominant in cystic fibrosis. So that's a different endotype altogether. Neutrophilic, Pseudomonas, gravitational drainage, medial maxillectomies, turbinectomies. Cystic fibrosis patients have a lifespan, definite lifespan. That is a definite mortality ultimately with the, lung failure.
What investigation you run, sir, for diagnosis?
Sweat chloride, and then genetic testing.
Genetic testing.
Nowadays, a lot of genetic, CFTR gene modifiers are in market. Cost is a limiting factor, but they work and improve the, mucociliary clearance.
Execution of engineers, please take their vehicles out.
Mucolites have a big role.
Special mention of these 6 vehicles.
See this topical
Yes, sir.
decongestion.
5351 6998
Now see the picture after decongestion. You saw the initial picture.
7838 P04 P064. Thank you.
See the turbinate coming in picture. Middle turbinate. Oh,
Yes, we can
compress.
see that. Thank you.
Oh, compress.
We haven't talked about this. So, let me say about this.
See the amount of polyps medial to the middle turbinate. I told you, and that destabilizes the middle turbinate. See this.
Yes.
These are the candidates to me which are cases or ideal candidates for partial turbinectomy. These patients often present with olfactory loss. See this everted uncinate process. This is everted uncinate. Completely distorted middle meatus. Can you see?
Yes, sir.
This is Bullach model. You see this? How distorted it is. massive polyposis. See the amount of polyposis medial to the middle turbinate. Ultimate condition of the middle turbinate is, see how floppy it is. So this is after luminal clearance. Bulla, uncinate, middle turbinate, everything deformed. Everything deformed because of the olive. So in massive polyp, you must be prepared to deal with, anticipate such issues. They are not uncommon.
Sir, can you tell us what precautions should be taken while using debrider in such distorted anatomy?
While using,
Debrider?
keep the cutting edges under view and keep the surrounding landmarks under view. Not blindly.
Right.
See, the picture is good. See the axilla, all polyps removed from everywhere. Same thing is to be done on the opposite side. Such patients, somebody asked me about upfront CT scan.
Yes, sir.
Such patient with massive polyposis coming to me, I would never wait for the medical treatment to be effective. Such are the cases which require direct CT scan. Such are direct surgical candidates. This massive polyposis is never going to subside with any medical treatment.
Right, sir.
So we need to know this practical fact. In spite of being a medical disease, now the inflammatory profile is so big that removal of the inflammatory load is necessary for the medical treatment, that is topical medication, to be effective. See the terminate. See so floppy terminate. This is distorted uncinate. Terminate is here. I told you even before starting, these are the cases for partial turbinate resection. See the polyp medial to the middle turbinate?
Yes, sir.
Once you see polyp medial to the middle turbinate, you are going to destabilize the turbinate definitely. Massive disease. See, turbinate is very small, compressed medially, and this is all distorted uncinate. Distorted uncinate, distorted bulla. See the interior of the bulla. So you have to be careful not to get disoriented. This is what I have done so far. It's just luminal clearance. Pure luminal clearance.
Dr. Satish, there are some questions from the audience, if it is okay to ask at this stage.
Hello?
Hello. There are some questions from our delegates, if it is
Yeah.
okay to ask you at this stage.
Yeah, please.
Yeah, Dr. Hetham from CEL, he wants to ask which tests you ask for invasive fungal sinusitis.
Which?
Which tests do you ask for invasive fungal sinusitis?
The invasive fungal sinusitis are of two types. The chronic invasive, that is mostly aspergillosis, and acute fulminant, we all know that is mucormycosis. Both are different disease. Obviously, invasive fungus is a pure medical disease, but they have certain role of surgery as well. Invasive fungus means antifungals. Chronic invasive is aspergillosis, and that is mostly diagnosed on the radiological grounds. Almost always can be diagnosed on the radiological basis, which requires histopathological confirmation of fungal invasion of mucosa. So, like for example, if you ask about the non-invasive fungus AFRS, for example, this is because of the antigen antibody reaction, and you'll find a lot of fungus with antigenic material and eosinophilic material around it, blocking the sinuses, expanding the sinuses, expansile bony erosions. That's it. In invasive fungus, chronic invasive, you will find involvement of the sinus with minimal intrasinus disease, with bone erosion at one place and maximal extrasinus disease. Bone erosion at one place and in continuity extrasinus disease with no expansile erosion of the sinus. It is truly invasion of the fungus leading to bone erosion. And in those cases, obviously, like for aspergillosis chronic invasive, voriconazole is the drug of choice and treatment is medical only. But what all role of the surgery is to establish a histopathological diagnosis of confirmation of the fungal invasion of the mucosa. So you need surgery for the biopsy, You need surgery for if the sinus is in any situation blocked for its ventilation and drainage, you can open up. There is no need of removing the fungal mass as such. Once you establish a chronic invasive fungal sinusitis diagnosis, voriconazole will take care of entire mass. In acute fulminant, the role of MRI is amazing, game changing. Treatment of choice, like I said, for invasive fungus is antifungal, and for acute fulminant, it is liposomal amphotericin B. But acute fulminant has a predilection of involvement of vessels and block them and give vascular necrosis. So, if the antifungal is not reaching there to the necrotic area, there is no fun in giving antifungal. So what we do? Advise MRI, see the enhancing area after gadolinium contrast. Wherever the gadolinium is reaching, no need to remove that. Your antifungal will reach. Wherever there is lack of enhancement, gadolinium is not reaching, immediately debride that for the antifungal to be effective to the enhancing areas. So MRI guides you for the surgical as well as medical treatment. MRI diagnosis by means of non-enhancing lesions. MRI will guide the extent of surgery also. It's not that all enhancing area need to be removed and unnecessarily giving morbidity. Only non-enhancing need to be removed. Enhancing will be taken care of by amphotericin.
Sir, we have lost the endoscopic picture.
You have lost?
Yeah, now we are on.
Yeah. I just back. See now the picture after luminal clearance
Yes, sir.
Yes.
on the right side.
Yes, sir.
I hope Dr. Rokade that answers your question.
Yes, thank you. There was a question for Dr. Hetal from SAIL, but I hope you got his answer. Thank you. So we're
Hello, one
very briefly-
four-wheeler MH6998 31FA to be removed from the parking area. FA.
This is the distorted uncinate process, what I told you. Can you see?
Yes, sir.
This is pure distorted uncinate process, and you should be able to pick it. Otherwise, one may get confused with a middle turbinate or anything. This is pure distorted uncinate process.
Dr. Satish, we're going to take a very brief break to the other center to know about the case, and we'll come back straight away to you again.
Okay.
Thank you. So could we join London very briefly?
Now, see this. After the uncinate plate partially excised, this is uncinate, this is hiatus seminaris. Can you see?
Yes, sir.
And this is your bullite modalis.
Yes,
This is
sir.
hiatus. This is infundibulum. And now our anatomy is becoming clearer. See this? This is your maxillary sinus. The chronically inflamed mucosa. Here I am biased to give a little bigger opening. Looking at the need of the topical steroids in the post-op, looking at the disease profile, such patient requires more vigorous.
Okay. Are we on? But I don't know if they. Can you hear us now?
Yes, Isham, we can hear you. Okay, so can you go over to London, please, for okay, thank you.
Thanks, Ashok. So this is our second case. It says case 4, but this is the second case. I just want to thank Mark Ferguson, that's his patient. This patient, I'll show you the slide now, presented, he's 45 or 46 years old, presented with left side nasal obstruction more than the right side, and rhinorrhea, sometimes green, sometimes infected, no epistaxis, no pain, no change of the sense of smell. On examination, there was very clear appearance of a large polyp which is extended into the nasopharynx, and most probably that would be an antiquinal. And when we did the CT scan, that really almost confirms this. I'll show you in a minute. Low density lobulated polyp measuring at least 5 by 2 centimeters. It's arising from the left maxillary sinus and protruding into through the large accessory ostium, which is always the case in these polyps. They always come through an accessory ostium and they extend it into the nasopharynx, and you will see it in the scan in a minute. And some mucosal thickening into the sinus itself, you always see with this. So if I show you the next slide, which will show the scan, you could see the coronal section on the left and the axial on the right. The axial is the best one to show this. In the coronal, you see this thickening in the bottom of the sinus with some opening, and you can't see the rest of the polyp. But it's really nice to look at the axial scan because it shows that nasopharyngeal extension of the antroquinal polyp coming through the accessory ostium into the nasopharynx. And this is really almost diagnostic. Obviously, you always have to exclude other things. In the majority of cases, it is correct diagnosis just from that CT scan. So what I'll do is we're going to do the surgery in a minute. We'll excise that polyp completely, and I'll explain what I'm doing it. So I'll go on scrub, and I will leave you with the other operation for now. Thank you very much.
Thank you. Thank you.
Great, thank you.
Okay, cool.
Sorry.
Over to Nakul, please. Dr. Satish, we joined you back.
I think they're muted at the moment. We might need to turn the sound back on the feed.
I'm sure you are oriented.
Yes, sir.
See this? I'm taking red putty, the bulla is there down. And I am reaching. First of all, defining the level of lamina. See, this is lamina.
Yes, sir.
Can you see the level of lamina?
Yes, sir.
This is axilla, which I am opening more and more. This is all axilla and the frontal sinus above. Now I'll change to 70 degree. So we'll finish in next 10 minutes quickly. See now the middle meatal antrostomy?
Yes, sir.
Clear?
Clear.
This is, we opened up the axilla above. Now I'm changing to 70 degree. See this now. See now the same landmark. Can you see the beak? Hello?
Yes, sir.
Yes, sir.
The key is define the axilla. This is axilla. This is axilla here. This is your beak. This is your medial limit. This is the lateral limit. This is lamina. And if I follow the beak,
Are you still with RAD 40, sir?
pardon?
Are you still with RAD 40 blade?
No, this is not red 40. This is red 120 now. See, I am putting underneath the beak to show you the frontal. This side we all know the frontal sinus is not big. We have seen on CT scan.
Yes, sir.
Remember?
Yes, sir.
6998 गाड़ी किसकी है 6998 अपनी
That is my frontal sinus on this side. See that?
Yes, sir.
The small frontal sinus, we all know the opposite side is relatively bigger. See, under the beak. See, that is the frontal sinus. So this was a small frontal sinus. And the beak is so prominent. See, this beak is so prominent. This is your frontal sinus. That is your frontal sinus. See that?
Yes, sir.
This is beak. I'll clean off this and show you. See, this is beak. And just behind the beak, between my medial and lateral limit. That is my frontal sinus. That is there. Data. See what we have done. Just for the beak. See this prominent beak and the frontal is up there. See?
Yes, sir.
Reverse. This is frontal reset. Try and something. Reverse. This reverse.
please.
Can I have the forceps? The
The skull being flushed.
okay.
Flushed.
Yes. Are we on?
Hello.
Yes.
Show them. Can we hear them?
Yes, I can.
Can I show you is it the polyp now? So let's look at the left side. Remember he complains of bilateral obstruction. So going here is a middle turbinate. When I lift, you see this polyp coming through that is very large ostium. That's not the natural ostium because the natural ostium is more anterior. Here's the uncinate. The natural ostium should be a bit here. So it's coming just from there and going backwards toward the nasopharynx here, filling it. If you come out and you go to the right side, you will see it filling the nasopharynx here as well. So that's why it's blocked bilaterally. So that extension of the polyp is very large, going all filling that nasopharynx. That's why the patient presented with bilateral obstruction. So what we'll do is you have to remove the polyp and the mucosa that caused it. If you just remove that polyp and that's it, it will recur immediately. It will recur very quickly. So that's a narrow stalk that comes through the accessory ostium here. So I'll start by removing that part, and then we're going to enlarge this accessory ostium connected to the natural ostium, and then we'll remove that mucosa. The great majority of these polyps come from the posterior wall of the sinus. And you will see that there's a minority that comes from the floor and really rarely come anteriorly. So we'll try to grab this narrow part of the polyp and take it out. So let's see if we can do that. You can get this part here and just gently tear it off. See if we can bring it out. Part of it. Sometimes they're so big, like they're so stuck in the back, and we have to debride them. But I'm going to have a go with this again to see if we can get it out. I think it's possibly too big to actually take out completely in one piece. So let's have a look again. Okay, well, it's coming. Here's a nice piece. Now let's look at the rest of it. Now, the interesting thing about the antrochoanal polyps, they're most commonly affecting males. The histology is different from the standard polyp. They're more fibrous. So they're not that natural inflammatory like the polyps that you see in patients with IG inflammatory conditions and so on. So they are different pathology. They're more a form of like a fibrous cyst that comes from the maxillary sinus mucosa. They're very rarely something called the sphenochoanal polyps, which originate in the sphenoid. They are extremely rare, but they have the same histology. I'm going to use a debrider. This is quite thick to remove from the nasopharynx. So I'm going to debride that part first. Yeah, nasal polyp. So I'll give you more. I will debride that part. So see how big it is in that nasopharynx. You can see why the patient is completely blocked. And I'm almost like creating a cavity inside that lump, really. So we publish a series of antrochoanal polyps in adults. So a lot of the time they'll present in children or adolescents. And so actually for them to present in adults, it's a bit rarer because the symptoms will start earlier because they would have been there for years. If they left them for a long time, they present in adult age. That's why You don't find a lot of published series in enterochoanal polyps in adults. So we published a series maybe about 7 to 8 years ago, and at the time it was the largest in the world. Interestingly, I was a bit surprised with it. And we showed that they always, or great majority, will appear from the mucosa in the posterior sinus wall. And all of them came through an accessory ostium. Now, interestingly, I'm going to look at it on the other side and also debride it. And you see with the debrider, because it's quite fibrous, it doesn't easily just debride it completely. They are very different histology from the standard polyp as just mentioned. So creating a smaller piece of tissue that we'll be able to remove. I remember on one occasion, one of these polyps was so large, we had to remove it through the mouth, actually. So this is coming out. Let's have a Blakesley. And we send all this as well. Looking again onto the left side suction. That seems a bit more loose. Let's have a Blakesley. So here is that big part of the polyp. So now we concentrate on the maxillary sinus. Let's have the FREER first. I'm probably going to change into 30 or 45 degrees so I can show you inside. Yeah, well, let's change our scope. So if you see there, here is the rest of the polyp coming through. So what I'm going to do now, I'm going to do uncinectomy, and I am going to enlarge the natural ostium, and then I'll remove the root of the polyp. So can I have the seeker first, and then we'll change the scope. It's always better to look, yeah. That's perfect. Yeah, I'll need let's have a 45 actually. So I'll medialize. I like to medialize the uncinets like this. It's safer when you remove them. And I tend to use a debrider to remove the uncinets process. When you medialize them, it's safe. You know you're not on the lateral wall. You're not affecting the orbit. So you can remove them like this with the debrider. So I'll do that now. So that is the uncinectomy. We'll start seeing into the cavity of the maxillary sinus. Okay, can I have the backbiter? No, FREER first, sorry. Yeah, backbiter. Face is a little tight, but we're here. We'll try from superiorly. Okay, let's do it again. Let's just have the FREER again. Yeah, back five again. So we just remove that rest of that onsonant. And then anteriorly. And the bridle. Now you can see accessory, natural. I'm gonna connect them. Maybe so I can show you better. I'm gonna now change my scope into the 45 degrees. So let's change the scope. And can we have also the curved sucker? Yeah, change the scope first, and then you can have that. Thank you very much. So this is the 45 scope. We just adjust it. Let's have a curved sucker as well. Yeah, this one, perfect. See the natural ostium here and the accessory ostium here. And this is the bridge between them. So we enlarge this, we're gonna enlarge a bit more. See where the polyp is coming from? You can see it inside the sinus. So I need to enlarge a little bit more anterior and superiorly here. So I can see the whole of the mucosa, just have the debrider, and then I'll remove it. It's really essential to do this, otherwise it will just recur. So now let's try to connect this. I will soon need a curved debrider. Actually, yeah, let's have a curved debrider. Before that, I'll have a straight Blakeslee or a chomper if you have one. So I'm connecting the two ostia. So now you can see that I have a larger opening. This is blocked a little bit. Yeah, let's have the curved one. Great. So now I change to a curved debrider. Just enlarging that.